Okay, well, thank you for all coming, and a lot of what I'm going to say is going to resonate in part with what you were saying. Basically, I was looking at Irish nurses' family-focused practice, and at the beginning I thought I was going to be looking at a large group of nurses who were not being family-focused, and we'd be talking a lot about barriers and about organisational barriers in particular, but I actually found that there were quite a few that were being family-focused. So I'm going to focus quite a bit on that today. So my motive came from practicing as a registered psychiatric nurse in Ireland and not being family focused at all for quite a long period of time. And then I went off to Australia, and I thought that they were substantially more family focused than typical Irish RPN. And when I came back from Australia, then I got into education, and I found that across our 4 years of our nursing degree programme, which specialised just for psychiatric nurses, we were very lucky, had a distinct specialist nursing qualification for 4 years, and not 1 hour within the 4 years was allocated towards family or family-focused practice. So this kind of got me thinking, and I decided to do kind of like comparative research really, to look at RPNs in Australia and how they compared with RPNs in Ireland, and what the family-focused practice was like, what they'd done, what kind of activities they carried out, what they didn't do, and what enabled them and what deterred them. So I used a mixed methods approach, and I started in 2007 and I've just finished. And what I done was I collected data of nurses in Ireland nationally, and I looked at nurses working in acute admission units where I had worked, and I looked at nurses working in community mental health services to see was there any differences in their practice and what those differences might be and why they were there in the first instance. And then I compared the data with the Australian nurses. I used the same survey that had been used in Australia so that I could compare between the two countries. And I had thought that the Australian nurses were able to be more family focused, and that was because they would have more educational input and at least regional policy development. There's no national policy with regard to children and parents with mental illness in Australia, but there's a lot of regional development, and so I thought that that would have impacted. Whereas in Ireland, there's no national policy and there's no regional development either. There's nothing really spoken about in terms of parental mental illness, either in education or in practice. We don't have any assessment documentation that asks about children. It's not factored into care. Often parents come in and they have recurrent depression, and they might have 8 children living in a high-rise flat, and the staff wouldn't be aware of that or its impact into the parents' depression either. And so I expected for those reasons that Irish nurses would be less family focused. And I used Adrian Falcott's model to look at the nurses' practice. And so Adrian has 6 domains that we should all consider if we're being family focused. And I used that as a benchmark to see how the nurses in Ireland related to those 6 domains. Did they factor them in? Without knowing about the model, would their practice have any resonance with what he was talking about, which is good practice in terms of family focused work? So overall, I got a decent response rate, 57%. But I got that by going to each mental health service over a year and a half of doing preparatory field work to educate the nurses and their managers about what I was going to look at. And initially, a lot of them were very hesitant, and they said, well, I'm not family focused, I'm going to be upfront about it. My organisation doesn't promote it, I don't think about it, so I don't want to fill out the questionnaire. But I give them a very broad definition of what family focused practice could entail. And it could entail enhancing your parents' mental health. It could entail talking to them about their wider life apart from their schizophrenia or their depression, and then having some conversations about their wider family context, and maybe having discussions at some stage with regard to their children. So there's large amounts of things they could do, and referral to outside services. All of those little things could be little bits of ingredients towards being family focused. So when they were aware of that, they were less cautious, and they thought, well, maybe I can complete this questionnaire and tick some of the boxes, and so they proceeded. So I did find that Irish RPNs were substantially less family focused than Australian RPNs. And there was a Likert scale ranging from 1 to 7, and strongly agree or strongly disagree, or disagree. My nurses tick most of those. They either strongly disagreed or disagreed that they don't most of the activities. Whereas the Australian nurses, they agreed, or they tended to agree that they've done quite a few things. So out of the 346 nurses that completed the questionnaire, 109 of them were actually very family focused. They strongly agreed or agreed that they've done several different activities. I don't know if you can really see that, but when I looked at this group that were doing things, and overall I was looking at what might influence them in being family focused. And the three largest circles were the things that predicted the family focused practice most. And that was skill and knowledge, and the fact that they were in the community. So those with most skill and knowledge in terms of family focused practice, and who were working as community mental health nurses, and who were parents themselves, tended to be most family focused. And what Angela was saying in terms of being in an organisation that kind of nurtures your capacity, it's very important. The nurses that were working in the community were saying, well, we feel family focused because we're working in small teams, we get supervision on a weekly or monthly basis. It's part of the community mental health team structures. There's good relationships between professional disciplines, and each has their own caseload. There's a lot of flexibility in the day, and in terms of scope of practice, what they take on. They're not confined to doing certain roles in a certain way. They use a biopsychosocial approach, so therefore they're more holistic and they can take more things on board. They're not just considering the parent's illness and the treatment of that medically. Within the community, they had more opportunity for sustained relationships with the parents, and some of them, in fact many of them, were working with parents over the course of 30 or 40 years. So they knew about their children, they knew about the grandparents, and they were in the homes up to 50% of their working time. So they had a kind of a social supportive, almost friendly one-to-one interaction with a lot of the parents. The parents got used to them coming in and out of their homes, and they'd seen them as a support. And they were able to see them as a support because they were non-judgmental, because of the capacity for the sustained relationship. Again, because the community nurse was being invited into the parents' home. And the parents were very vulnerable, but in a sense their vulnerability was reduced because they were inviting the professional in, and so therefore the professional was aware of that all of the time. The nurses in the acute area found more of a hierarchy between the parent and themselves. They were seen as more of an expert, and the parent was in their space, whereas the community nurse was in the parent space, and so had to work harder at establishing a good rapport, and that worked to the benefit of both. Another huge thing, apart from the fact that they were a community nurse and being nurtured by their own organisation, was the fact that they were parents themselves. The majority of the high scorers were parents, and they said that that gave them something in common with the parent almost immediately, where they could discuss the challenges of being a normal parent. What does every normal parent experience? And so it was kind of like a uniting force they used. And they were able to engage in limited self-disclosure, and that way really engage with the parent. They were able to use their gender as well. Being a parent, like the male nurses said, I would have man-up conversations with the men. I would say, what kind of father do you want to be? And I was able to talk in language that he would understand, that he wouldn't feel offended about. And fathers, nurses who were fathers themselves, also had a bit of insight what it was like to be a male, to be a father, and the whole pride issue. And they would have said, we find, the men who are parents are harder to kind of like, they're harder to work with, they take longer time to work with, they take more time to become confident that you're not going to be judging them, to open up. But they were aware of that from the offset because they themselves were male. So there was gender issues that also impacted the practice and enabled the practice as well, if they understood the role of gender in the whole thing. Most of the things that facilitated their practice was community setting and their own competence around their parenting. But other things like, again, interprofessional practice, that was a big thing, again, within the teams they learn from each other. So in Ireland they don't have any family-focused education or policy, but that didn't matter in a sense because they were learning from each other within the team and they were sharing their skills together and building up their wealth of information, especially if they stayed in these teams for long periods of time and their skills were developing from month to month, from year to year. Okay, so when I found this all out and I found that 109 were high scorers, I was interested to find out, well, what was their practice really like. So I interviewed 14 of them, and four of these RPNs were from the acute area, and the rest were from the community. And basically I found out that the practice really entails activities, principles and processes. So they have a number of main activities. They have about 5 main categories of activities that they will conduct and carry out on a regular basis, and I'll talk a little bit more about that in a short time. These activities were contingent upon principles that they held themselves, and I'll go through those. And then there was processes that they enacted to carry out the activities, and also then the capacity was influenced by these enablers, barriers, and some scope for potential developments to occur with regard to family-focused practice. But I would say with all of the things, it was all interlinked, but it all kind of hinged on principles. You know, the principles dictated how able they were and how they performed the activities, why they done things, and how they done them. Okay. So again, I'll read down to it, so you probably won't be able to see that. So there was 4 main activities that they performed. These high scorers would say, well, as soon as the parent comes in, regardless of the fact that there's no assessment documentation compelling us to ask about the children, we would ask about the children. And the reason they'd done that for most of them was they were working in the community, they were observing normal family life from day to day. They said, you know, when you knock on that door, if you're not going to ask about parenting, you're not doing your job properly. You're seeing the dysfunction right in front of the door, you have got to kind of help the person with it. And it's just normal daily life. If you can talk to them about that in your encounter, you're impacting them, and through them then you're impacting the children. And a lot of it too was, you know, they perceived that if they were facilitating the parent's recovery, that they really had to address the fact that they were a parent, because they recognised that parenting and the stress of being a parent could impact the parent's mental health. And their main remit was to address the parent's mental health. But in doing that, they had to know that they were a parent in the first instance. This was one of the variables that was going to impact on the mental health, and to address that. And so they understood that they could reduce the parent's chance of relapse by addressing parenting issues, but at the same time, when the parent felt more stable, that would impact upon the children, and then the vicious cycle of each affecting the other negatively could be stemmed. And so that was one of the principles that they operated from. The next thing that they done was they did actually engage and support children and other adult family members, but it tended to be mostly older children, those over the ages of 8. And some of them did sit down with the children and ask them what they understood about the parents' mental illness. But mostly they talked to the adult relatives, you know, about the children's welfare, the parents' capacity to cope, what the adult family member could do to promote the parents' capacity to cope. The reasons why they didn't talk to the children, younger children, was because they felt ill-equipped. They didn't feel that they had the language to help the child understand it in a safe way. But they attributed that to a lack of education about children within their curriculum, and they wanted more of that to be able to do their job properly. And then the last activity they done was collaborate with others. The community nurses in particular did that really well. you know, we have a time of recession in Ireland, but these nurses will go into every organisation that existed to promote family functioning. And it might have been like activities, Gaelic activities in youth clubs for the children. They were going into the schools, any kind of service that existed that could be used by the family. They were becoming known to that service and working with them. And then in terms of principles, there was 4 main principles, and one of them was, as I've said before, why were they doing all of this? It was their remit, because their remit is to address the parents' mental health, and they couldn't do that by ignoring the family context. It was very much embroiled in the whole thing, and it was very obvious working in the community to see that. The other thing was that they did feel they could support children via the parents. And they were very strong in their belief about this. And they just felt that by improving the parents' mental health, the well-being and the quality of life of that child was going to be drastically improved. And I would give small examples like coming to a house and the curtains all being shut, and coming in and speaking to the mother and the children would all be lined up on the sofa, really quiet from the age of 3 up. And they would have conversations with the mother about opening the blinds and just letting the children play at the front door. And that was a major improvement. Just small things, and seeing it benefit both the mother and the child. Okay, the importance of the parent-nurse relationship. I've mentioned that in terms of it's a process and a principle. This is how the nurse helped the parent and then helped the child through the parent, was with the relationship that the nurse had with the parent. As I said before, it was almost like a friend. They were a friend. They were a friend to the parent. And they did find, though, that because we were with the parent for quite sustained periods, and there was a lot of complexity and emotionally fraught situations where children were being removed from the parent, at times it could be very difficult. And on one particular case, one of the nurses said she had 2 parents who had depression, but they also had intellectual disabilities. And in the end, their children were taken off them because they weren't able to read the time, and they didn't know when to feed the children and do ordinary everyday things, but they dearly loved their children, but it was very, very emotionally taxing to be involved in all of that. And so they said it's a general thing within our work. You have to acknowledge that it is going to be complex and arduous and emotionally challenging when you're working with families like that. And also then that it needs to be individualistic, individualised and holistic, and looking at all the unique needs of each family. And again, that was motivated by the fact that, that's the way care has to be. And again, that's the reason we're looking at parenting in the first instance. They're compelled to do it because care has to be individualised and holistic, and look at the broad picture for each family. With regard to the process of how they've done it, they had a partnership, a day and daily partnership with the parent. It was very strengths-based, and the parent was really the expert, and they were just there to kind of be a sounding board and to help the person articulate all their emotions about being a parent and the challenge from day to day of being a parent. They also drew on principles of therapeutic interventions, so they didn't have any nice things like family talk or child talk or any of those specific types of child-focused interventions, but they used cognitive behavioural therapy, solution-focused therapy, any of those broad therapies that most psychiatric nurses do get within their curriculum to kind of like help the parent think in a more constructive way about how they are as a parent and what they were doing. And mostly as well the use of home visits to observe normal family life. And sometimes we would do impromptu home visits so that they could come in and see the children with the parent once the child had got home from school. And the child was screaming and the parent was screaming back, and they would be in the middle of it all, just observing but also helping. So that was basically what the nature and scope of the practice was about. So it was very comprehensive, and they would have said to me that 80% of the time was involved with promoting their capacity to be effective parents. That's what their role was as a nurse. The RPNs in the acute described all these things as well, those 4 RPNs, but to a lesser extent. And the reason they mostly give was the structures in the community. Even if you're very family focused, what these 4 nurses in the acute area were, they were 4 very family focused nurses. but their organisational support weren't as nurturing as a community were in terms of the team structures, the interprofessional conversations and discussions and teamwork that was going on, capacity for supervision. All of those things were absent really from the acute services, and that deterred them from being family focused, even though they were trying to be family focused. And they had values, good values about being family focused. They were parents themselves. They knew about the impact of parental mental illness. They wanted to do something. They strived to do something more than they were doing. They were curtailed somewhat by their organisation. So these things I have talked about, so I'm just going to flick them up. But these are some of the quotes that I would have illustrated what they meant. So my own experience as a mother is one of the most important factors in it, to be honest. Most of us are aware of our own children's needs, and then you can see when a child, and you think their needs aren't being met, and you just become more aware. So another said, because you have a sense of these are the trigger times, you can ask, empathise, understand, and you're also able to say to clients, I know what that's like, I have kids. It gives you a route to be able to say what that's like for yourself. So another talked about the awareness of the impact of parenting on parents' mental health. So I think there's an obligation on you to be family focused. If you're treating a parent, because children can affect the parent's mental health, so you have to be involved with the family as well. A lot of them talked about this whole thing of getting into the home and observing normal family life. It's not really something you can see around a bedside when the mother or father is admitted into an acute admission unit. You can see it played out in the home. So you could be there when the children were coming in from school and you see how it's working, or you could drop in the evening. You can see a mum on her own when the children have gone out of the house, and if everything is rosy and she's making it out to be rosy. And you could go back the next evening when the children are in and there's chaos. It's a good learning curve for me as well as for the mum to see how she is managing. Sometimes we sit down away from the children after the children had calmed down and she had calmed down, and we would talk about what had happened with the interaction that was going on with the children and the parent. And give them some of them said, like, I'm like super nanny, 911. I spend a lot of my time saying, when my child talks to me like this is how I feel. But I know this is what I should be doing, and I see that you didn't, or you did, whatever, and could almost coach the parent about parenting. So I did mention before about the sustained relationships, and one particular nurse said she had a lot of women that she was coming to that are in their 40s. So I've been with them all along when their children have been very small, and some of these children are now having children. So there's a whole cycle that goes into what we do with the families. That gives us a different relationship with people and allows us to make interventions in a different way than other professionals that are coming in with the purpose of making a specific intervention. So that's about the whole sustained relationship that promotes it. And then another key thing, as I've said, was the whole partnership process of just having that relationship on a daily basis and building it up through time, not to be an expert who's coming in and telling them how to do things, but to use a strengths-based approach and to get the parent to kind of resolve their own issues. And that's very much informed by the nurse knowing the parent and what the strengths of the parent are. And one nurse said, it doesn't go well for relationships with parents if you come in and make decisions and taking control away from them as parents. I think everything has to be done with them. The whole thing is to get them on board. So they were really quite enlightened with a lot of emotional intelligence, Angela, as you were talking about, these particularly high-scoring nurses. And it wasn't that they got it through their education or that they're compelled to do it through policy or that they were being supported in terms of documentation and any kind of obligation. They were parents themselves. They were living with these people a good part of their life. They were going to work 5 days a week and maybe visiting same parents twice a week when they needed the help. And they were observing normal family life and talking to them about normal family challenges as part of their work. And that's it.
We have about 5 5 minutes for any sort of questions or comments.
I was wondering, you had a definition about family focused.
Yes.
6 items or 7 items.
It was a family that was, well, I had a broad definition at the start of the questionnaire, and it was, so family-focused practice could be your practice in supporting the parent's mental health, and it could also entail talking to the parent about issues around parenting that would impact on their mental health, but also about their children's well-being. And then within the questionnaire there was 6 activities, and the rest of the items were things that would predict those activities. But the activities would be, do you collaborate with outside services? Do you speak to the children about parent with mental illness and how they would understand it? Do you talk to the parent about the impact of their mental illness on their children? So it was broad, very broad-based activities.
Do you actually do any parent training like PEP, or anything of that sort?
They have support groups, and they would refer them. The nurses would say, if it's normal parenting stuff, I do it one-to-one with my parents, and my organisation supports me to do it. I can spend any amount of time with them as long as I prioritise my caseload, and if I think a parent needs an hour on parenting support, I'll factor that into my time that particular day. But if they need anything that's a bit more complex than talking about the normal challenges of parenting, albeit with a mental illness, then I refer them to psychology or to other support groups. If the children were having behavioural difficulties that were more than just discipline issues or interactions and relationships between the parent and the child, if it was more sustained behavioural problems, then I would recommend that the parent would access the parent support groups and other services.
Thanks, Anne. I was interested in how you used Adrian Falco's model to look at your data.
Yeah, I looked at the activities that the nurses undertook, and I found out that they were very much into domain 1, so they were very aware of the impact of parental mental illness on the child's well-being, and they did address that. They were very, very aware of domain 2 and the fact that difficulties that children may have may then cause a relapse for their parents' mental health. So they were very focused on that and addressing that. They were also addressing domain 3 because that's about family relationships and about the child's relationship with the parent. And they spent a large part of the time sitting down role-playing. And one nurse would have said to me, the parent would say to me that the child would throw all her clothes down the stairs and say, go and wash them, and she would have lots of abusive language to the parent as the parent would pick the clothes up at the bottom of the stairs and go and wash them. And so she would role play with the parent what to do if the child threw the clothes down the stairs. So she would go to the top of the stairwell, throw all the child's clothes down, and say to the parent, now what should you do? And that was to kind of like tip the clothes and put them in the garbage, or do something, whatever it was that the nurse advised. They would talk around that about good relationship between the parent and the nurse to promote a good relationship. So that was domain 3. Domain 4, they did a lot of the socio-economic stuff. Community nurses were in there acting as social workers, getting their social needs met. They've done very much of that. The whole thing about quality mental health services really impacting, well, they were doing that day and daily because they were such champions and high scores and very family focused. And they were aware that the quality of the contact with the parent was crucial for the parent and the child and the wider family. And with regard to culture, they didn't do very well with that. None of them really talked about the wider, apart from community services, they didn't really talk about the cultural needs. 25% of the Irish population wouldn't be Irish-speaking white, and that wasn't a part of the data at all. It wasn't mentioned. Differences in different types of families in terms of their ethnicity or the impact that would have on their needs as a parent and as a family. But it was a very good model and to use as a lens to look at their practice across 6 domains. Good way to structure it. Okay, thank you.